Okay, good morning everyone, welcome. For those of you who don't know me, I'm Andrew Bateman, Chair of Trustees of this fabulous charity, and I'm so pleased to welcome you all here. This conference has gone from strength to strength, in no small part due to the terrific organising team and the sponsors and exhibitors. Please make sure you really engage with our exhibitors and sponsors who are here, because meetings like this can't happen without their support, and they need to know about each of your interests. So I've written a little welcome speech that's in your book, so I'm not going to patronise you by reading that to you. But I do want to say how proud I am for what I think this programme looks like today. I think this core central involvement of people with lived experience driving everything that we're doing has really got better and better each year, and I think you'll see that through this morning's work and everything that happens today. So I'm not going to take any more time because I want to get over to the important business. I don't think we need to say anything about the usual advisories, so just have a really lovely day. Do come and say hello. Do engage with us through the year. Do tell people to join the charity. Your individual membership enables us to do the work that we're trying to do, and I really am grateful for your membership. So over to kick us off. James Piercy is going to take us through this next section of the day, and James is a fellow trustee of the charity. So where's James? Just like magic, he's going to appear on stage. Thanks, James.
Pretty. So we are going to spend the whole day talking about acquired brain injury of various forms, and they're a room full of amazingly clever and intelligent people, and you're all terrible compared to the people that I'm going to introduce you to now, who really understand this stuff because they have lived experience of brain injury. So if you could welcome to the stage Aaron and Michaela and Julie. Cool. Julie in there, and I'll sit in there. Fantastic. So I thought what we could do just to start off really is just have a bit of a conversation really. So we have a range of different kinds of experience on the stage in front of you. We'll hear a little bit more about what happened to Aaron and Michaela in a moment. My own story is that I had a brain injury in a car accident in 2011, and it was called a severe brain injury. And I guess one of the things we want to unpick in this first session in the morning is what does that mean? And I'm going to ask the other people that are kind of with me on stage to describe a little bit about what happened to them and the kind of language that was used to describe the injuries that they had as well. So perhaps we can start with you, Michaela. Can you just tell us what happened to you and when did it happen?
I had a car accident in 2018 and I had a severe brain injury from that. So my car went spinning around and everything. But yeah.
Yeah, so a serious accident. And
yeah,
Julie is Michaela's lovely mum.
Hi.
And Julie, we can only imagine how awful it must be that your daughter's had this accident. What was she like when you first saw her in hospital? What kind of injuries had Michaela had?
Okay, so when we first saw Michaela, she was in a trauma, and the evening started off with a phone call by the police to say your daughter's had an accident, she's very poorly, you need to get to hospital ASAP. And originally the police were going to take us, but then they realised that we were going across borders, so we'd have to change cars. So my husband said, no, I'm driving, and he drove. I think we must have broke some speed records that night. And they wouldn't let us see her initially. We had to identify her by her jewellery. But the trauma unit were waiting for us, so as soon as we'd identified Michaela by her jewellery, we were taken to see Michaela. Michaela actually looked perfect. No marks, no blood, no scratches, nothing. But at the accident, they'd put her in an induced coma. So she was just wired up, and they'd just done an MRI. They came over to us and they said, you know, this is very serious. We don't know if she's going to make it or not. We don't know if she's going to make it through the night, but she's got to have surgery.
They kept saying that the next 24 hours are critical, the next 48 hours are critical, etc.
Yeah, and they just kept asking us if we understood what they were saying. Well, we were just, we could hear it, but, you know, it's really hard to think, actually, can I understand what they're telling us? No. Yeah. They said it's very significant, her injury and her brain injury, and she will need surgery.
Wow. So was the brain injury ever described as being severe or very severe? Was that kind of language used?
Yeah. It was on a board in front of her, and at that moment she was still adult unknown, because she had to be identified. She was adult unknown, and they said a significant brain injury, obviously because they got some of the scans back at that point. But then later on, when she was admitted to ICU, they actually said she was in a vegetative state. And they weren't sure uncertain about if she would make it. I think it took 4 days for her pupils to react to anything at all, so it was very touch and go. And they just said she would be in a vegetative state. And then a little bit later, when we got to rehab, they actually said that the most we could expect from our daughter was 24-hour nursing care if she survived.
Wow. Well, we can see that's not the case, but we're going to leave that lingering there for a moment before we find out the next part of your story, because I want to talk to Aaron, because Aaron, your story is quite different. What happened to your brain? What was your accident?
Yeah, so I was mountain biking with friends after COVID in the Lake District. I don't know exactly what happened because I can't remember, but the marks on my face were somewhere on here, and they drove me to A&E. I kept asking, what's happening? What's happening? I think I hit my head, repeating myself. But at the A&E, they sent me for a CT scan, and it came out clear. So the doctor basically said to me, it's just a concussion, you're fine. Here's your head injury leaflet. If you vomit twice or have a seizure, then come back, but otherwise that's all we can do.
Yeah, so I guess you're sort of uber mild.
Yeah.
in the language, and you were fine, yeah? So you got your piece of paper, you weren't sick, everything's cool?
It seemed all right at the start, and then everything went downhill. When I went back to London, I started trying to work on my PhD again. Every time I tried to concentrate, like, I would just get very intense headaches. And if I try to, you know, go back home on a bus or something, then I have to get off and walk home because, like, there's too much motion sickness. And I couldn't even go to a cafe to, you know, have a chat with friends because it's too loud and too noisy. So basically, life sucks. Yeah.
And I guess it was obvious to you that was because of the mental accident. Yeah. So what did you do? Did you go to the GP and say, look, this is what's happening to me, help?
I looked online, maybe because I'm young, and found various things on YouTube. Basically, the summary was, it's too complicated, find a concussion specialist. So I did, and he tested me for different problems in my brain, different dysfunctions, and gave me corresponding rehab. I mean, banned me from my bike. Life still sort of sucks during rehab, but then I had something to do.
Yeah, and how long did that process take? So you've come out of the ED, you've got your piece of paper.
Yeah.
Is it like a couple of weeks later? You think I've got to do something, or are we talking like a year? Or
2 weeks in, I was like, this is crazy. I can't deal with this. But so I sought help very, very early. But then the actual rehab took maybe a few months.
Yeah. Okay, interesting. So we often use this expression that we heard Aaron say there, just a concussion. Let's ban that. Should we agree in the room that we're not going to ever say that again? Because it's kind of meaningless. And this term that you've got on traumatic brain injury, I don't think you'd describe your experience as being mild in any way.
No. It's I think the experience is anything but mild. I think I can see why the term is there in terms of I wasn't dying, but I think it somehow works for some bits of it and doesn't work for other bits.
Yeah, so we get this mild, moderate, severe language, which is really just describing the condition on presentation, isn't it? It's the early stage. But actually what we really need is something which tells us a bit about outcome, about prognosis, and how we describe those things. So let's come back and pick up Michaela's story. You've got a severe brain injury.
Yeah.
You're told that, you might be all right, but you're going to need 24-hour care.
Yeah.
And what do you remember, Michaela? What's the earliest thing you remember when you came out of a coma?
Memory from me is once I had my titanium plated, and it was the lady on the next bed to me in neuro hospital, and she was put on there because I didn't know what to do with her. So she had dementia, and she used to attack everybody, but I was okay because I was just a child.
So that was lucky. Your age helped you out there. Yeah.
Yeah, about a year later, that's when I had a titanium plate, and that's when my real memory began.
Yeah, it's interesting. You were saying to us last night that actually it made a real difference when you got that cranioplasty plate. Suddenly it almost seemed your brain was like, hello.
My brain knew that something was missing, and that having that titanium plate was like, oh, okay, I can work now.
Yeah, fantastic. And Julie, how did you see that progression? So how long was Michaela kept in that coma for, and what happened as she kind of came out of it?
She had PDOC for probably, there was no response for probably about 6-7 weeks, and then she was referred to another rehab out of intensive care to do a 12-week program, a sensory program. It's called STAR, to see if she'd react to anything, because at that point it was just when they do like a finger prick, and that was the only, like, pain was the only thing that there was any response, and that was very, very minimal. So they did a STAR program, and during that time she started to respond more. But as parents, we saw a lot more, I think I was explaining last night, in terms of her blood pressure readings, her heart rate. When certain people were nearby, it would fluctuate on a very regular basis. Myself and my husband stayed with her for 6 weeks, 24 hours a day. The only time they wouldn't let us move from her side was when the consultants went round and when they were washing her. So we saw a lot. We saw things like her eyebrows moving, her lashes twitching, the occasional finger twitching.
But parents see what they want to see, don't they?
And that's what we were told. Parents see what they want to see, and they were involuntary movements.
Yeah, but you were thinking, no, actually, Michaela's in there and she's trying to get out.
Absolutely. And James, I think she told you last night, didn't she, about her experience of being in a unconscious state?
Yeah. So I could hear things, not like to respond, but I sort of know that things are going on. Like, you can't put a face to the name, but you hear things. And I knew, like, I could smell people were there. But so when they say they're in a coma, they won't hear, you won't know you're here, but you do know that people are there, you know who's there, you can hear them.
Yeah, you've got that awareness that there's people around. So I want to pick up on the language with you two as well. So we've heard Aaron was described as mild, but I'm not sure that really means very much. How do you feel about being called severe or very severely injured? Do you think that made it harder to get better, or was it useful?
No, it sort of put like a negative opinion on me that I'm severe and I can't do this because I'm severe, and I can't do that because I'm severe. But then in a way it sort of helps, because I guess you could get services more than others because you are severe. Do you know what I mean? Yeah. What do you think?
I think for us to be told that your daughter's in a vegetative state is very, very frightening.
And it's dehumanising too.
Yeah, it was quite upsetting, because, like, she's our daughter, and then everything you see or hear about a vegetative state is very, very negative. And we was even handed a brochure at the first multidisciplinary meeting where all the professionals got together, telling us the definition of vegetative state and the definition of locked in. And it was just, just here's this piece of paper, this is your daughter. It was quite cold, really.
Yeah, terrifying. So It's about 7.5 years ago, and you're getting this sort of quite negative idea about what might happen. You might need 24-hour care. Michaela, tell us what you're doing now.
Right now I'm at University of Wolverhampton, but I'm studying special educational needs, disability and inclusion to give other people a voice, because I know I'm so here.
Second year. The second year. The second year.
Isn't that fantastic to hear about that kind of
I'm in my
progress?
second year now. But to be told that you're severe, the most you can expect is a 24-hour nursing home. But here I am, my second year of my degree, and it's a completely different degree to what I was doing before. So before I was at UEA doing physiotherapy, but now I'm at Wolverhampton.
Yeah, and I think what's the same about those degree courses, they're both about helping other people.
Yeah.
Aren't they? Yeah, and that's grand. So we have an issue as well with this word severe, don't we? I think it's easy that people can kind of feel that they're in a box, and maybe we don't put in the effort that we need to do to make them better, and those individuals and their families perhaps think, oh, well, maybe there's not much we can do.
Not much.
But also the outcome after severe is really different. So my brain injury was severe. I was back to work, albeit part-time, after 6 months. So I had a completely different trajectory.
Yeah.
So I think what we need is some kind of system of talking about brain injuries which gives us not just that kind of presentation, this is kind of where you are, but where will you be? Right? What can we say about people, about their injury, which might give us some kind of prognosis about what kind of future is going to be like? Aaron, I wonder if I can sort of come back to you. What would you have liked to have got? So rather than just this piece of paper that says, if you're sick, give us a ring, what kind of information would it have been helpful for you to get?
I think what you should be doing to get better, how much should you do with time. To be honest, I basically, I've started a startup with my concussion specialist to try to solve this problem. And we're trying to bring what I would have liked to get to everybody else, because you just get given a piece of paper. So we're trying to bring testing as well as rehab to everybody, because also it was very expensive. I was very lucky to have private insurance. So we're trying to bring that rehab and sort of not quite certainty. I don't think we know how long it's going to take, etc. But I think giving patients tools to actually have something to do, have something to track, to see your progress. I think the progress is also a big thing.
Yeah, and we're not just talking about sort of 1 or 2 people. We know that about half of the people that have a concussion will have symptoms 6 months afterwards. So there's a huge kind of cohort of people. And just to sort of wrap up our short conversation, really, I guess, Julie, what kind of information were you given at the start, and how could that have been different? Well, obviously, we don't want to give families and patients false hope, because some people won't make amazing recoveries like Michaela has done. Yeah. But do you think there could have been better description, better information early on for you?
Definitely. I believe totally that, not false hope, but we were given no hope. And I think that's a massive difference. We were given no hope at all. And along the way, I did challenge quite a lot. Well, something would have been better than nothing. Yeah. So I think everyone has strengths, and I think even if you can just identify the slightest thing, it makes a difference. When we tried to talk to consultants after they did their ward round, and I know consultants are really busy and they're really pressurised, but it would just be no change, and they'd walk off and they just wouldn't want to say any more or talk about any more, and that was really frustrating as a family. Even like, there's no change at the moment, but maybe, or we'll let you know more this day, or this is going to happen next. There was none of that. Yeah.
Excellent. Thanks very much. Well, listen, we are out of time for our conversation, but please give it a big round of applause to our patient speakers. Right. So, we just wanted to start the summit really by having that conversation and talk to some people with kind of experience, and really to pick away at this idea of this simple single word description of brain injury, which I think we've shown is kind of a bit sort of meaningless. And certainly for patients and families, we need to know about the future. We need to have a better understanding of people's condition and presentation and what that's like to be like in the future, which is my seamless segue to our keynote speaker, Professor Geoff Manley, who is going to talk about a new kind of system for classifying traumatic brain injuries. So please welcome Geoff to the stage.
Thank you very much for inviting me here today. And I'm not sure that the rationale for what I'm about to speak about really needs any more introduction than we just heard from these patients. Thank you very much. You know, we've been doing the same thing for at least 50 years now. It was over 51 years ago that Sir Graham Teasdale basically came up with Brian Jeanette, the GCS, which we've used to acutely characterize traumatic brain injury patients now for almost probably 2 generations of physicians, and to simply divide this into mild, moderate, and severe. And I'll talk a little bit more about the motivation. These are my conflicts of interest, which there are none here. And a lot of this started back in 2007, where we convened a workshop to try to think about why all of our clinical trials in traumatic brain injury had failed to that point. And the recommendations out of this conference were to establish better databases, which I'll talk about in a second, start to standardize how we describe head CTs, more widespread use of MRI scans, which we know are much more sensitive than CT scans, start to standardize some of our outcome measures that we use, to develop common data elements, which are basically ways in which we can capture data in a standardized fashion, whether we're doing this in the UK or the EU or North America, South America, to start thinking more about special populations in particular. Certainly in North America, the fastest growing population of folks with traumatic brain injury are older adults. And so we really need to pay more attention to that because we don't have a lot of data there. But where we really failed was developing a more precise classification of TBI. What this did do, however, is that it did bring on a tremendous amount of interest from the European Commission, the Canadian Institute of Health Research, the National Institutes of Health. Certainly the conflicts that we've witnessed in Iraq, Afghanistan, which there's been strong participation from the British, from the United States, Canada, and others, really highlighted us to what we just heard, that mild really isn't mild for many people. And so we had a number of agencies start to bring more resources and support to this area to better understand the natural history. And companies started becoming involved, which has been very important. Philanthropy, which I think is also key to success in this area. And as a result, there were a number of studies that were launched. So Track TBI is a study that I've been fortunate to help coordinate in the United States. Center TBI, which was led out of Great Britain and Belgium. There are several investigators here from Center TBI today. We had a thing called the Grand Alliance, the CARE Consortium, where we've studied over 30,000 collegiate athletes and looked at the impact of concussion and trying to develop better prediction models. And as a result of all these studies, we really ended up with what I would call a mountain of data, data that we never had before. We had a lot of data on what happens with people with quote-unquote severe TBI, but not a lot of information on patients that had what we would have considered to be milder injuries, but aren't always mild. In 2022, there was a committee that was convened by our National Academies of Science, Engineering, and Medicine, and we laid out a 10-year plan for clinical care and research in traumatic brain injury. And I want to draw your attention to the first recommendation, which was to create and implement an updated classification system for TBI. What we heard consistently was what you just heard here, which is that this system is not only failing us in research, but it's failing us in clinical care, and it's failing our patients, basically. And I stand, in front of you here today in 2025, and we're talking about the most complicated injury and the most complicated organ in the body. And here we're using terms like mild, moderate, severe, concussion. And I like to sort of tongue-in-cheek say, if I were to go to our Food and Drug Administration, which is the agency that approves drugs in America, and to say, I have a drug for severe TBI, and they would look at me as if I were crazy. I mean, what do you mean severe TBI? Excuse me, back up a little bit, a little jet lag there. Is that, for cancer, I mean, we would never say for cancer a severe cancer. The reason why we treat cancer today is we don't call it severe. We don't call it mild. We're very, very precise in how we describe this. And as a result, many cancers are now treatable and beatable. So what's really wrong with this? And again, I don't think I really have to reinforce this based upon what we just heard, but there is no modern treatable disease that uses such an imprecise classification. There's just not. We don't classify any disease in this way that we have a treatment for. As you just heard, mild is not always mild and severe is not always severe. There's no association with mechanism. There's no effective targeted treatment. And this bias that we heard, and in particular in the United States, severe creates a tremendous bias. I don't know the statistics here in the UK, but in the United States, the single leading cause of death of severe TBI is withdrawal of life-sustaining therapies. And that happens in our country at a median of 3 days. So what that means is that half the people that receive a diagnosis of severe TBI in the United States have care withdrawn on them within 3 days. We have all kinds of research from Center TBI, from Track TBI, showing that many of these patients, in fact, 20% of them will have a full recovery, as we just heard from James, within a year. So we really need to stop doing this. And again, as I just said, patients and families don't really want us using these terms. So last year in January, we convened a workshop at the NIH to try to really talk about how are we classifying TBI, what is the nomenclature. And the aims of this were to really try to move us beyond mild, moderate, and severe, beyond these terms, to produce really a more precise framework that would allow us to describe injuries in ways that would lead to better treatment and clinical care. To identify gaps in the research topics, to try to say, well, what do we know from all the work that we've been doing in the last 15 years, and what do we need to know? And to really develop and then think about how we implement a global solution for multidimensional TBI characterization. And again, the goal to move us beyond mild, moderate, severe. So this is the steering committee for the workshop. Some of you may know my colleague, Andrew Moss, who was from the Netherlands, worked in Belgium for a while. Mike McCrae, who is a colleague of mine, very well known in sport TBI injuries. Mike developed the first sidelines assessment of concussion about 25 years ago, which is now used by FIFA and organizations all over the world. Kristen Dams-O'Connor, who works in the rehab space, and then some of our NIH colleagues. This was an international effort, so you can see some of the working group chairs, David Menon from Cambridge, Heinrich Zetterberg, who's from Scandinavia, Lindsay Wilson, who is just up the road up here in Stirling. So many people, and some of the folks that are here in the audience today were on the working groups. So this was meant to be an international effort. If we're going to really try to change something, we need to do this with broad buy-in and lots of support around the world. We assembled a number of working groups. So a clinical working group to try to think about what are the clinical features that we would describe an individual. An imaging working group where we talked a little bit about how are we using imaging. Blood-based biomarkers, which I'll talk a little bit more about. This is really a new tool that is just now becoming available. I don't know the availability here in Great Britain, but we have a handful of hospitals in the United States that have implemented this, but more are coming on every month. To really think about, importantly, the psychosocial and environmental modifiers, and importantly, to think about knowledge to practice. This was an idea that Andrew Moss had, which was we shouldn't wait to develop something to figure out how to implement it. We actually need to figure out how to implement it as we're developing it so that we can understand what the gaps are. And I think that we could have even done more work on this as we're now looking at how to implement this broadly. And retrospective classification, this is something that some of you may have seen. Not everybody comes to the hospital after an injury, and some people will slip and fall from a ladder ladder on their house, and they'll show up 2 to 3 days later. Some people show up 3 months later. And so how do we retrospectively establish a classification for TBI? Because these patients actually need it. Without a diagnosis, it's hard to treat anything. And so trying to figure out how to do that is challenging. So there's a lot of challenges here. We've used these terms my entire professional career. The generation of physicians before me used these terms. So we're talking about a culture that it's going to be very, very hard to change this. So, what we aspire to do versus what we can do, we need to balance that. Are we talking about classification, or are we talking about characterization? And what I would say to you is we're trying to better characterize, and from better characterizations, ultimately, we will build better classification systems. But these classification systems are going to be complicated. They are not going to be as simple as mild, moderate, or severe. But I would tell you that for anyone who, unfortunately, in this room has been diagnosed with cancer, or someone that's been diagnosed with cancer, or if you're a clinician and you've ever been to a tumor board where we're talking about somebody's cancer, there's nothing simple about that. They're not saying this patient has severe cancer. They basically go through and outline all of these characteristics of the cancer. And from that, that's how you develop a targeted treatment. And that's why people are surviving from cancer today. I mean, if we think about it, look where breast cancer, colon cancer, things like this, even lung cancer were 20 years ago. And the reason why we've gotten to the point where we are is that we are characterizing these tumors better to develop better classification. Is this diagnostic or is it prognostic? We want it to be both, right? You want to be able to say that we have a framework that tells us not only what to do within the first 24 hours, but how are people going to do at 6 months, at 12 months, and further on down the road. Adult versus pediatric, we had pediatric colleagues that were part of this, trying to better understand how do we look at kids. Very challenging to really characterize a traumatic brain injury in a 6-month-old, but I think some of these tools that we'll tell you about will help to do that. And ultimately, it was really about trying to come up with an 80% solution. We're just not going to fix this in one go, but we have to make the turn to start to do something different. So I'll share with you the framework. And the framework starts with what we call the CBIM model, and it's the C, the B, the I. It's the clinical, it's the blood-based biomarkers, and it's the imaging. And importantly, it's also the modifiers. So one way to think about this is that the C, the B, the I is what the injury brings to you. But the M is what you bring to the injury. And it's very, very important because not all of us are the same, and we bring different things to the injury. There's the patient factors, there's the injury factors, and importantly, there's the social and environmental factors. What I noticed looking at all the vendors outside, and thank all the vendors for supporting this incredible venue here today, is that there seems to be a lot of support out there. Probably more support than there are in the United States. I mean, it's very challenging to get any kind of follow-up care or any kind of rehabilitation services in the United States just based on our fee-for-service health system. And so having the right sort of social and environmental factors, as we heard about up here, is really a key for people's recovery. And we'll get into that a little bit more in a second. We wanted this to be not only for research, but also for clinical applications. And what this is, I don't know, has anybody here heard of the TNM system for tumors? Anybody? So I'll explain. So yeah, got a few hands going up. So in the 1940s, there was a French physician. At that time, the way they described cancer was all over the place. Some people would show up with a tumor and they're like, oh, it's a really big tumor, it's a really small tumor, and trying to figure out, well, what's your prognosis with this big tumor or this small tumor? And it was known that if you had, for example, with breast cancer, positive lymph nodes, that your prognosis was probably worse, or worse yet, if you had metastases, that the prognosis was worse. And so we developed a classification system or a characterization system for cancer called TNM, where we use this to not only describe what the patient looked like in front of us, but also to prognose their outcome. And within about a decade, basically every person that had cancer anywhere in the world, they were using the TNM system to characterize this, and they still use it today. It is the beginning of a characterization system of any tumor that any of us, God willing, we would not have. But if you did have, they would start with that. But of course now it's all imaging, it's molecular, it's biomarkers, it's all of these things, as I said earlier, that make these treatable and beatable. So the CBIM is sort of a riff on this, which is to come up with a more simple classification system maybe than cancer, certainly more complicated. And I think this has been one of the criticisms of what we proposed 4 or 5 months ago, is that this is a little bit more complicated, but I think the brain's complicated. And I think that if we're not going to embrace the complexity of the problem we're dealing with, we're going to continue to fail. And so, we're just going to have to buck up and just accept that this is going to be a little bit harder to do, but it's going to be important for patients for us to do this. So the GCS, although I said that, this has been used and simplified into mild, moderate, severe, it remains the cornerstone. And it is one of these systems that I think is worldwide. It's used. It is the basis of how we characterize somebody. However, if you think about some of the limitations, if you go all the way over to the right, which is 15, which our friend here may have been a 14 or 15 after his mountain bike accident, but most of the people that arrive at hospitals, at least in North America, show up as a 15. And theoretically, all of us in the room this morning are GCS of 15. So in fact, there's really a ceiling effect of how we would describe these people with higher GCSs. And yet we do know that the lower that your GCS is, the higher probability of having findings on imaging and the higher probability of unfortunate or unfavorable outcome. So what we're proposing then is to basically use this clinical pillar, which is the GCS and also the pupils. We've known forever that pupillary dysfunction, if you blow a pupil or if both of your pupils are dilated, that this is really an emergency and also associated with more unfavorable outcome. But as a neurosurgeon, it's also associated with an opportunity for improvement. So if someone comes in with an epidural hematoma with a blown pupil, we get them to the operating room rapidly. These are people that can actually have a favorable outcome. So in the expanded form of this, starting to talk about, post-traumatic amnesia, loss of consciousness, using standardized symptoms assessments, really trying to implement better characterization of these patients with higher GCSs and lower GCSs. But this is really the clinical pillar. The biomarker pillar here is newer. And so this pillar is based upon really data that's been generated over the last 20 years that shows that there are proteins that are normally in your brain and should not be found in your bloodstream. And so these are proteins where you can draw some blood and you can measure these things. This is very similar to if you have chest pain and you go into an emergency department today with chest pain, what will they do? They will do a blood test and they will look for a protein called troponin, because troponin is supposed to be in your heart, not in your bloodstream. And so we know as clinicians, what I know as a neurosurgeon, because I don't know much about the heart, this is my part of the body I take care of, is if I have elevated troponin, I need to call a cardiologist. And so the same way is that these proteins hold promise, that if you see these proteins in the bloodstream, we can then help to diagnose or aid in the diagnosis of traumatic brain injury. And this isn't just science. 3 of these proteins have been approved in Europe for assessment of patients with traumatic brain injury. There's GFAP, there's UCHL1, and there's S100, and they come on very quickly. In the United States, the GFAP and UCHL1 have been approved, and we're now working with Roche to look at the utility of S100 in aid in diagnosis of traumatic brain injury. So while these are very new, and this is forward-looking, we anticipate that probably within the next 5 to 10 years, most hospitals will be using this. And a couple of my colleagues that are here today, Drs. Lucky and Newcomb, they're starting to work with looking at some implementation projects with blood-based biomarkers to understand better how we use them. These are not the answer to everything, just like the GCS isn't the answer to everything, but these proteins are ways in which we can, at least currently, rule out the need for a head CT. Now as we see that when these proteins are elevated, to help us aid in the diagnosis. So what we've proposed is to basically look, at least in the acute setting, with GFAP, UCHL1, or S100, or a combination thereof. Right now, what we know, say for example, with the GFAP, is that no one in this room should have a GFAP above 71 using the Abbott platform. And so the cutoff right now to rule out the need for a head CT is 30. So if it's below 30, you don't need to expose yourself to radiation. And we know now, there was just another paper that was published 3 months ago showing that radiation exposure is associated with the development of cancer. So we don't want to unnecessarily expose people to radiation if they don't need it. But what we know also is that if that's above 100, 110, that it's likely that you've had a brain injury. So you're going to see evolution of how we use these tools, just like we saw evolution of how we use things like troponin. The other thing that is on the forefront is a protein called neurofilament light. And several companies are looking at neurofilament light now. And this is a protein that appears on day one, but by 2 weeks, it's almost 8 times as high as it was on day one. And what that allows you to do is to retrospectively classify TBI. So if somebody shows up in your emergency department, or say, for example, a doctor's office, and they said, gosh, I fell off of a ladder 3 days ago, 4 days ago, 5 days ago, last week, I feel terrible. Probably in the future, we're going to be able to order this test and determine whether or not they actually sustained a brain injury when they fell off that ladder. Switching gears again, talking about imaging. So imaging is very important. I just talked about CT scans. We heard that when our colleague here fell off of his bicycle, they ordered a head CT and it was normal. I'm sure that they looked at the head CT and the young lady over here. But what we've learned is that head CTs don't tell the whole story. We've seen both in center and in track that a substantial number of people that have had a normal head CT will have findings on an MRI scan. And so we know that the MRI, and what those yellow arrows are pointing to on the right in the MRI scan, are what we call microhemorrhages or petechial hemorrhages on a CT scan. And we've now relabeled those TAMV, which is a traumatic axonal microvascular injury. Big mouthful of words, basically just saying that you've had these very small lesions that are usually associated with axonal injury, which means that you're disconnecting your brain. And so we've learned that a lot of these people can get reconnected over time with good rehabilitation services and things of that nature. So we know that imaging is super important. In fact, it's probably the only objective marker of injury that we have today. It's very hard to clinically diagnose brain injury. That's why we order a lot of head CTs to rule out more significant injuries. But you know, if you're a brain injured patient and you want to basically have positive evidence that you've had this, you know, a finding on an MRI or a CT will do that. But we know that people that have no findings on either one of these imaging modalities will actually end up having traumatic brain injury. So we still need to do a better job with this, and people are looking at advanced imaging techniques all over the world to try to do that. So with the imaging pillar, there's this updated term, as I talked about. The components really now focus just on head CT because that is the workhorse of the first 24 hours. And for us to start recording things like epidural hematoma, subdural hematoma, subarachnoid hemorrhage, contusion, there's many different kinds of lesions that you can see here. And this is very challenging, right? Because our radiologists don't always want to do this in a standardized way. And we're starting to look at AI or machine learning tools that have been applied to stroke to try to basically do a little bit better job with this. So the last component of this is the modifiers. And we've definitely been here before. So this is a study now that is 45 years old. And there was a study in North America called the Traumatic Coma Data Bank. This was a very important study in that it really bridged from a lot of the work that was being done in Glasgow. There was a database that was being collected there, and then some American colleagues had a grant funded by the NIH to start looking at more profound brain injury or severe brain injury. You know, from that we learned about, you know, the importance of maintaining blood pressure and oxygenation and things that really changed care in brain injury. But at the same time, there was a smaller subgroup of this study that was looking at what we called minor head injury or mild traumatic brain injury. And what they found is that that in fact these patients didn't do so well. And things like the extent of organic brain damage that could be seen on a CT scan, even when their GCSs were 15, were associated with unfavorable outcome. They also noted that, how people responded to their trauma. The trauma response was important. What kind of rehab they got or didn't get turned out to be important. And things like social support, where you were, where you lived, where your access to care was. And so even back then, and I think we probably didn't pay enough attention to this paper, we learned that it's about the injury and who comes to the injury and how you respond to the injury. So it's not just the C, the B, and the I, but who you are and what you bring to this. And it's important for us to understand this. I think if we look at some of the recommendations here, we basically are recommending a complicated framework here. So what I would say is everybody, I think, buys into the clinical, which is that we're going to assess the GCS when you come in. We're going to look at your pupils. Fine, we do that right now. There's nothing that complicated about it. The blood-based biomarkers, it's a blood test, okay? What's the challenge with the blood-based biomarkers is that this is just dissemination, implementation. The tests are relatively comparable to the price of most other tests that we would order, like a troponin test or something like that in the hospital. And as more companies make these, of course, there will be competition and the price will go down for those tests. The imaging, we already do a ton of CT scans. I suspect that the data is the same in Great Britain as it is in the United States. We believe that we probably order 10 times as many head CTs as we need. At our hospital, we order 30 to 50 head CTs a day for usually about 3 people or 4 people or 5 people that will have findings on that head CT because, again, in defense of our healthcare system, we're trying to rule out a severe injury because, and see, I'm using that term right now, a more significant injury with, somebody that has a higher GCS but has findings on a head CT. We need to do a lot of work on these modifiers because right now we have a laundry list. And the way that we need to do this is we need to start doing research. And we're doing this now with our Center TBI colleagues and our folks in TRAC. And we're trying now to understand, what are the most important features that we should be asking our emergency room colleagues to collect, because there's mechanism of injury, there's extracranial injury, were there stressful circumstances, and by that I mean, was there domestic violence, was there an assault? I mean, these things, when you have a life-threatening injury and you perceive that your life is being threatened, that thing is hardwired, since we were living in caves, that when something is life-threatening, you need to remember that for the rest of your life so that you can have the rest of your life. And so this is another thing we probably have not paid enough attention to, is the circumstances of injury and what that does to our brains. And it actually rewires our brains in ways that make us very susceptible to things like post-traumatic stress syndrome. Age, are you young? Are you old? Whether or not you're a man or a woman, we know that women, for example, that have sport concussion are more likely to have long-term complications than men. Why is that? We need to understand that better. The community and society issues are also very important. Social disadvantage, what kind of health coverage you have, that's very important in America, where we have a fee-for-service system. And even when we start to expand this and think about things like, we definitely need to understand what kind of medications people are on. So you can see there's a very, very long list. So it's much easier to look at somebody's GCS and say you're mild. Simple, right? To collect these modifiers is challenging. However, what I would say is that this is, again, a place for AI and machine learning. How many people here have used ChatGPT? Yeah, the whole room. Why do you use ChatGPT? Because it quickly harvests a lot of information and then poof, within minutes, puts up bullet points for you to summarize everything going on. There are tools today being used in North America that do this in healthcare. For the last 24 months, within the last 24 months, there are now upwards of 4,000 hospitals in our country that use AI tools to harvest information for stroke care. So we know that in stroke, time is brain. And so when you come into a hospital, the clock is ticking if you have a stroke. But there are modifiers that are there. There's all kinds of things that are there. And so what these tools are doing, in the same way that everybody just raised their hand for ChatGPT, think about this as a ChatGPT for healthcare. This thing is now taking your imaging and processing it. It can bring in information from your blood-based biomarkers, and it can then go out and look through your electronic medical record, figure out what your sex is, how old you are, what kind of medications you are on. So what we're getting pushback for, in this is that, oh, it's too complicated, we'll never do it. Probably today, us working as humans, it's too complicated. Think how complicated it would be for you to gather all the information that ChatGPT can gather for you on your phone as you're sitting here, maybe bored and doing a little ChatGPT right now for my lecture, is that we can basically do this. This will happen. It's already happening in stroke, and we hope to bring this to traumatic brain injury within the next 3 to 5 years. So I'm going to give you some examples here as we start to wind down. So this is somebody that we would have typically referred to as mild TBI. I refer to this young man here, over here on the left, which I know very well from Saturday nights in San Francisco, as the young dumb male. I mean, this is somebody who comes in, there's alcohol on their breath, there's a laceration on the chin, and, historically we say, well, we got this guy down here with mild TBI, I think there's something on the head CT. Oh, that's a positive head CT. And I'm like, well, what do you mean positive head CT? Because I'm not in the hospital. I'm talking to my resident on the phone. But how much more precise is this if my resident called me up and said, I have somebody here with a GCS of 14. They have a GFAP of 400. I just said normal shouldn't be above 71. They have a subarachnoid hemorrhage. I'm now getting a much better, more precise characterization of this individual than if they called me up with the same patient and said, well, I've got somebody here with a GCS of 14. GFAP 3,200, subarachnoid hemorrhage contusion. I'm starting to think, even though I haven't even been able to get onto my electronic medical record to pull up this scan, I'm already starting to think I might need to go into the hospital because the GFAP is 3,200, we've got subarachnoid hemorrhage, we've got contusion. And if you look at this scan, you can see the ventricles, which are those dark slits there, they're moved to the right side of the brain there. They should not be there. They should be right in the middle because you've got a contusion that's expanding. And this is a patient that will likely need surgery within about 30 minutes. And so being able to be notified about that, to know about this earlier, to get a blood test even as you're going for a head CT to tell you what this looks like. So at the same time, you're starting to basically not only see the head CT, but you're starting to quantify the degree of injury with these blood-based biomarkers. It's pretty simple. If it's low, you're unlikely to see injuries. If it's super high, you're going to see more injuries. And so we also know from some papers published out of Center and Track that the amount of blood, these blood-based biomarkers that you have is also prognostic. So I think, hopefully I've made the case for the C, the B, the I of how we could use that to better characterize. But what about the M? We have a patient here, it's a patient on the left, graduate education, employed, supportive family, access to resources. How do we think this patient's going to do? Yeah, I'm seeing heads going up and down. Probably okay. How about this patient? 10th grade education, unemployed, alcohol use disorder, at least in our country, homeless. Not very well, right? Fortunately, I live in a city where we believe in public health, and we have a very robust public health system, and I'm fortunate enough to have a couple of psych social workers that when we identify a patient like this, we wrap around them because they don't have a family to wrap around them. And we try to keep these patients from getting worse. We try to make sure that they have some housing that way they can get and seek out some health care. So I think that, hopefully I've convinced you that having these modifiers is important. It's complicated, it's challenging, but I think we have tools to do this. In terms of what we would call severe TBI, here's somebody that rolls in, 6T, that means that they've been intubated. Their GFAP is 8,000. This is super high. They have a subarachnoid hemorrhage, contusion, and subdural hematoma. Versus this patient here, GCS of 14, GFAP of 10. We probably shouldn't have even gotten a head CT in this patient. Normal head CT, but the blood alcohol is 400. This is just somebody that was having too much fun, and unfortunately fell, lost consciousness, and ended up getting intubated by our pre-hospital care providers. And unfortunately, we see this with some frequency as well. So everything that I've said is available online. The paper was published in Lancet Neurology about 3 or 4 months ago. There's also companion papers that describe each of the components of the clinical, the biomarkers, the imaging, the modifiers, implementation science plans, and all of this can be found online. We made these freely available, so you should be able to download these without any cost or issues with that. And I would encourage you to take a look at those. So what I hope I've convinced you of this morning is that we're really entering a new era of TBI. It's sort of like the 1940s when we stopped referring to cancers as big tumors or small tumors, and we started thinking about better characterization, which ultimately led to more markers and biomarkers and better imaging tools. And really, cancer is very different today than it was when I was a kid, when I was even in medical school. It's remarkable what's happened. And importantly, as we heard from our patients here, and I really want to thank them for their courage to be here in front of you and tell you about their life experiences, is that we just have to stop using these terms. We're not helping anybody. We're not figuring out how to better take care of patients. We're not figuring out how to come up with new treatments for patients. You know, again, we create a lot of bias and stigma when we use these terms for these individuals. So what are we doing with this now? Well, we actually have a study that we launched in the United States through some funding from the Department of Defense, where we're actually using the C, the B, the I to do a drug trial. So the drug trials that I was familiar with when I was a resident and early in my career that all failed, we were simply looking at patients with severe TBI. And if you go back and you look at those studies, upwards of 30–40% of these people that we enroll probably were inebriated. They didn't even have findings on a head CT. How could we have expected any of these clinical trials to work when many of these people probably did not have a quote-unquote brain injury? So what we've done is we've used the C. So we're looking at patients with GCS of 9 to 15. We're using the B. So you have to have GFAP above 100, and we have a point of care device where we can draw blood, and within 15 minutes we can get the results, and that can be used in the emergency department. We actually use it to enroll our clinical trial patients. We enrolled 3 this weekend. And then we're using the imaging, but we're excluding epidural hematoma because we've learned that epidural hematomas aren't actually associated with unfavorable outcome when treated rapidly. And we're doing what's called an adaptive platform trial, so it's more efficient. Rather than looking at 1 drug versus a placebo, we're actually looking at 3 drugs. For example, if you're a patient, you know, just like the folks we enrolled this weekend, you have basically a 3 out of 4 shot of actually getting drug. We're using some repurposed drugs. That means that we're using drugs that have been used for other conditions that have been shown to have some utility in this space. And really what we're trying to do is that we're actually just trying to learn how to do this, to be honest with you. I think that, you know, the idea of looking at a single point in time, so all these failed trials I told you about, basically we're done at 6 months, and we know that we need to do repeated measures. So in closing, the last thing I'll share with you is that we're starting to think about CBIM as a care model, as a new approach to treatment. So we're working with the national academies, with the American College of Surgeons, the American College of Emergency Physicians, also in discussions here with some British colleagues about you know, how we might think about globally implementing a care pathway where when you come in, we'll do the clinical assessment. We'll get the biomarkers to determine whether or not you need the head CT, and we'll collect these modifiers in order to be able to find the right treatment for the right patient at the right time and better characterize those, ultimately to lead to better outcome. So I think that we're really in a golden age of traumatic brain injury. It feels a lot like when I first got started and there was great hope. And, you know, we had CT scans, you know, we had some other things like this. And, you know, unfortunately, I think we just weren't embracing the complexity of the problem, just like our cancer doc friends have embraced the complexity of cancer. And so I think that we just need to just bite it off, because stories of having a young man here who struggled to get care, who finally got care, to have recovery, to be told you're never going to recover, to sadly be careful in the United States, because if you get diagnosed with severe TBI right now, until we change hearts and minds, withdrawal happens frequently, and we need to do something about that. So thank you very much again for inviting me. I hope I've helped out. So thank you.
Wow, Professor Manley, so many thanks for that. What a great continuing professional development opportunity for us all. I think we've all learned a huge amount in these. We've got a few minutes for questions, and we have some questions. So just a reminder, there's a Slido app which helps us know what to ask.
Excellent.
And I've got three questions that are quite linked and very, very interesting. So I think it's worth giving time to these. I think I'll start with Luke Griggs, who's here from our major head injury charity friends, Headway, and he's asked, to what extent does the limitations of scans or inconsistent access to them impact the ambitions of this important work, or do the biomarkers mitigate this?
Well, so what I would say is that this is still an evolution. What happens in our country is almost everybody gets scanned, and CT scans are widely available. Even in low and middle income countries now, CT scans are available. So I would say that the availability of CT scans is there. MRI, not so much. And we believe that the blood-based biomarkers will probably help us eliminate about 20% of the unnecessary scans. They're not perfect, about 20%. But what they will also help us to do is that when the blood-based biomarkers are elevated, but the CT scan is normal, there seems to be ranges that would say you've had a brain injury. There's other ranges that are even higher that would say maybe you need an MRI scan. So we're hoping that these things in concert can facilitate this, not only by reducing unnecessary head CTs, but prompting the utility of MRIs to provide patients with objective endpoints for diagnosis.
Terrific. This is a very collaborative conference, and I've got this wonderful question here. Somebody's asked about your aspirations for the CBIM model and how in the UK can we help?
Yes, well, I'm a huge fan of collaboration, and we have a standing call at least 7 a.m. Pacific every Monday where we're on the phone with European and UK collaborators. And I think we have to all do this together. This can't be something that's solved on one side of the pond or the other. And we're actually in active discussions, and we'll be discussing this afternoon, how we're working on this care pathway. We're working on the CBIM care pathway with an international group of clinicians to try to make sure that this is broadly available. So I would say that we have a lot to learn. I think that as we use these blood-based biomarkers, we're going to learn more about them. They're not the solution. They're one of the tools in a toolbox that needs to be full of tools. And right now, we've got the GCS and a CT scan. So that's probably not enough tools. And so the blood-based biomarkers will be another. But as we start to use this, that will refine our understanding about how it's going to work and how we tie all this together.
Terrific. Thanks. And another one that's just come in, there's an upvote system on Slido, by the way, so the favourite questions get bumped up to the top.
Okay.
And Mark Holloway has asked, as function is the goal of rehabilitation, I wonder what functional outcome measures could support the process of Prof. Manley's research?
I need all your help in answering that question. The gold standard right now for outcome assessment is the GOS or the GOSE. How many people have heard of this, the GOS or the GOSE? Yeah, we've got quite a few hands up here. I started off probably 10 or 15 years ago criticizing that outcome measure heavily. In track, we did about 20 outcome measures. And still the GOSE works pretty well, even though it's crude. I don't know that that's the right outcome measure. I think that trying to understand function in people, one of the reasons why it works so well is that you can tell somebody, whether or not you're a GOSE 8 or not. 8 means you're fully recovered. That means a lot. So what I would say is that I think we're still struggling and searching for the right outcome assessments. And we need everybody's help to figure this out because, as you just said, I feel sometimes very guilty in that in the acute setting, I have carte blanche to do whatever I want to do, at least in the United States. And, I take care of these people. I monitor brain oxygen and look for seizures and all this other stuff. And then it's like people go off the cliff when they go to rehab. And I really feel like we need better outcome measures to prove up that rehab works. That's one of the problems we have in America. They're like, well, where is the randomized controlled trial that shows that rehab works? I've done this for 25 years. I know it works, okay? And that doesn't sound very scientific, but I follow my patients closely, and I know I need to get my patients to rehab. But we have to be able to prove that up, and for that we need better outcome measures, and we're still searching. So we need your help to find a better outcome measure.
That's I'm going to echo that answer. Thanks so much, folks. There's so many more interesting questions that we're going to run out. We've run out of time to take. So. We're going to take a break now to fit in time for drinks and networking.
Sure, and I'll stick around. If you guys have any questions, feel free to come up and ask.
Yeah, thanks so much.
Yeah.
So it's really interesting questions here. Thanks a lot.
Pleasure. Thank you, sir. Thank you.